Good evening, everyone. And at the outset, I thank Dr. Puri as well as the Cardiomersion team for inviting us. Technology in surgery has made life difficult for the surgeon. What we were able to do, the open chest, now we have to do it with some small closed ones. Whereas technology was supposed to help the surgeon proceed and make his life easier, it has made my life difficult. Because earlier everyone could see, now only I can see. Okay, so today's topic, MICS, minimal invasive cardiac surgery. Although there is nothing minimal except the scar, rest all is maximal. So this is how the traditional cardiac surgery happens. We cut open the sternum. Problems, they are not exactly problems. Just because we are trying to accept something new, we would like to show that this is bad. But this is what the traditional cardiac surgery is. We cut the bone, but there is some pain. There may be chances of infection because we are cutting the bone. There may be an ugly scar. Cardiac surgery was never about cosmesis, but now everyone wants a cosmetic result. The patient may be immobilized for a period of time. For a young female, it has got a social stigma of that scar. And the most important factor is every patient has got a fear of a major surgery. Acha, haddi katega, bone katega, sara. And here you have to remember, the knife is competing with the needle, and the needle always wins. The needle is the cardiologist. So we have to evolve. Now this is the evolution of the cardiac surgeon right now. And that's the old cardiac surgeon still lying there. So that's the fact of the matter. If you don't evolve, you perish. So that's where MICS comes. So the most important factors, one is age. We usually consider both adults, males and females. Very young patients are not considered more because of a lack of the cannulas which we put rather than the technical difficulties. And the patient's clinical condition, whether it is stable or unstable, these are factors only in the beginning, but right now we consider all patients and the pattern of disease, critical or non-critical, and the body habitus, whether obese or a small built or a thin built one, whether the patient had a recent MI, lung conditions, a barrel chest, small chest. So these are all theoretical conditions, but if you want to have a program of minimal invasive cardiac surgery, none of these conditions apply. So you have to be able to do it in everything and everyone. So these are some of the basic investigations where an X-ray of the chest is done, where we locate the apex of the heart, the direction of the aorta, any lung pathology. All of these are factors which are important before you begin a program. Again remember, if you want to run a program, don't consider these. Take each and every patient inside and take him and operate and face your own hurdles and learn from it. Of course, we do HRCT. Not in all patients unless it's recommended if there is any lung pathology. And peripheral CT angio or a peripheral Doppler is a must because that's where we put in our calculus. A 2D echo of course and an angiogram. Most of the anesthetic preparation, we usually take the patient in the ICU one day before and then put them on injection Milanon therapy or levocimendon just to dilate the heart so that it makes our handling easier. And our double lumen tube was being put earlier, but nowadays we use the anesthetists use blockers. A left femoral line, a right femoral cannulation, and this is just a small. The long lines which you are seeing is of the sternotomy, and the small line which you see is the scar on the left side is the marking which we put for an incision. Each and every operation theatre should have a TE or a transechocardiac machine, which is a must if you are proceeding for MICS in all patients. And this is the retractor which we keep for harvesting the left internal mammary artery. This is usually set up once the patient is on the table. And these are the set of instruments which we use. The most important benefit is no bone is cut and there is less amount of pain, early recovery, and there is less infection. And since the handling is less, or the tissues, number of tissues which are being cut is less, so the blood loss is also less. And the most important factor is it's a boon for unmarried girls. Nowadays, it does not matter with unmarried girls. Even an old man of 75 or 80 is demanding that he does not want his bone cut. I think cosmesis is primary, which we never used to give importance. Some of the difficulties which any institution faces is each of the instrumentation costs is somewhere around 35 to 40 lakhs. Whenever you approach the hospital to buy these instrumentations, the first thing is what's the return on investment? You can't promise a return on investment on something which you are going to learn. So we perform all the procedures under the roof, like CABG is the most common one, aortic valve replacements, mitral valve, ASDs, cardiac tumor. We completed more than 250 cases and 200 of these were in the last year. Of course, we picked up later on. In the earlier phases, it's always a little bit difficult. A picture is worth a million words. So this is an ASD, a scar, not visible. So earlier the incision was submammary, now we changed it to axillary. So that's a minimal invasive mitral valve replacement. There is a CABG. There is again a mitral valve replacement, an axillary incision, same axillary incision. There is a post-op patient who came for follow-up for an ASD closure after 3 to 4 months. There is a hemisternotomy. Now we graduated to the right anterior thoracotomy once. There is a MVR in a female patient. Just a small video of right anterior thoracotomy approach for an aortic valve replacement. So incision is in the second intercostal space, just laterally on the right side. There is a soft tissue retractor. This guy was a bodybuilder. That's the valve being inserted. Since these tissues are at a depth, so we use a core knot, and that's the scar. And this is a scar on follow-up. So as apart from other patients who usually ask the mundane things like when can I eat, when can I walk, when can I sleep, this guy's first question before discharge was when can I start lifting weights. This is one more. This is a CABG. Since the space is limited, so this is a specialized octopus, or we call it the Nuvo octopus. The octopus itself costs somewhere around 5 lakhs. So these are all some of the financial constraints which I think we face in an MICS. There is a triple vessel disease, CABG. And that's the scar.